In this presentation, I am going to discuss how the minimal access surgery was started, what is the present status, and how it is going to be in the future. Minimal access surgery, it is called surgical rows with the different names. It is the same procedure which is called by different part of the world by the different name, like keyhole surgery, buttonhole surgery, band-aid surgery, minimally invasive surgery and minimal access surgery. These all are the synonym of the minimal access surgery. However, minimal access surgery was the most commonly used synonym, and all over the world, if you want to get the diploma or fellowship or masters, generally minimal access surgery synonym is used because that is the most catchy name, and it is minimal access means entering through the small hole, access means pathway of entry and exit. So, you have the minimal access. The branches of the minimal access surgery, there are different branches like laparoscopy, cystoscopy, hysteroscopy, arthroscopy, axilloscopy, vitreoscopy, retroperitoneoscopy. These all are the branches of the minimal access surgery. Now, the prefix is the organ where you will put your telescope, like lap means abdomen, thorax, bladder, uterus, vitreous tumor, axilla are joints, fallopian tube, and this scopy term was coined by Professor Hopkins. And the credit of revolutionizing minimal access surgery goes to this physicist who has invented the first rod lens system, and this is the scopy term he has coined. And Professor Hopkins is considered the pioneer who has first time in 1953 he has invented the first rod lens system, and today also this rod lens system is used everywhere. It does not matter which company you are using, any company you will buy telescope, like if you buy the Striker, if you buy Olympus, if you buy the Star, they all are using this Hopkins rod lens system. In this you have one eyepiece where you can attach the camera, or you can see by the naked eye also. After that you have the object lens, and in between you can see these are the rod lenses. And these rod lenses are very important because they are basically prism, and the light from one end will be transferred to the another end by the help of these rod lenses. So, this is how Hopkins has invented it, and today we are using it for minimal access surgery. Hopkins was a physicist, and once he has started this rod lens technology in the Britain, then he wanted to ask every company of the Britain to make it commercially available. Nobody was ready. So, then he went to Germany, and in the Germany one of his very important innovation was started by the Karl Storz, and together with the Hopkins and Karl Storz, they have established one company, and this was the first time this Hopkins rod lens system was commercially available by the Storz. Today also, if you will buy any telescope of the Storz, over the telescope you will see it is written the name of the Hopkins, and this is how the laparoscopy started. But the question is that is laparoscopy was started only in 1953? Basic laparoscope was invented in 1953, and that was a cystoscope, and now slowly this object lens, eyepiece and rod lenses were used in all the telescope, like if you want arthroscope, if you want retroperitoneoscope, if you want cystoscope, all is working with the same technology. Now, but history of minimal access surgery is even before that. First inspection of the abdominal cavity was started in 1901 by the Von Ott, and Von Ott has used this Lichter's endoscope, and this Lichter's endoscope was used with a simple candle light. He tried to see inside the abdominal cavity. This Lichter's endoscope was just a crude modification of the nasal speculum, which the ENT surgeon they see inside the nasal orifices. So Lichter's what Von Ott has done, he has given an incision in the right iliac fossa, and then he has introduced this Lichter's endoscope, and just using a candle light he tried to look into the abdominal cavity, and that was called cilioscopy. Because coelomic cavity, pituitary cavity has one more name, that is called coelomic cavity. And this was in 1901 first time anyone has tried to look into the peritoneal cavity, that is coelomic cavity. After that it was almost stopped. Nobody was interested to do this. Now once the Hopkins has invented the rod lens, then there was one male German gynecologist, his name was Professor Sem. He started doing a lot of diagnostic laparoscopy for the female of the chronic pelvic pain and infertility. And one day he saw a inflamed appendix, and he did the first appendectomy by using the laparoscope. And that was very interesting, that first general surgical procedure was performed by a gynecologist, and name was Professor Sem, and the year was 1983. So it is important that first general surgery was also performed by a gynecologist. 2 years later, Eric Muhe has performed in 1985 first cholecystectomy. After further 2 years later, Gare has performed in 1987 first hernia surgery. And again 2 years later, in 1989, Harry Rich has performed the first hysterectomy. So it is very interesting that the golden era of laparoscopy was 83 to 89. Most of the important surgery, like 83 it was appendectomy, 85 was cholecystectomy, 87 was hernia, and 89 was hysterectomy. And in between, most of the other surgeries also were performed, like the ventral hernia was performed, duodenal perforation was performed. So this era 83 to 89 is called golden era of laparoscopy. And most of the invention, like invention of the insufflator, invention of the digital camera, invention of the electrosurgical generator, harmonic, ligation, all were in this era. So this is called golden era of the evolution of minimal access surgery. After that, in 1993, the first robotic surgery was performed by Dan Stanvisi, and in 1994, first colorectal surgery was performed by Geese, and in 2001, first natural artificial transluminal endoscopic surgery was performed in the Strasbourg, France, and then first single incision laparoscopic surgery was performed in 2005 in Izmir in the Turkey. So these are the chronological milestone, how the laparoscopy was started and where we are today. However, if you will see, then there are hundreds of procedures which you can perform by minimal access surgery. In abdomen, almost entire procedure starting from abdomen, from esophagus to anus you can perform. In gynae, almost all the surgery in the chest, in the spine, in the urology, in the neck, in the axilla, in the breast, and now robotics. So basically, if you will see, there is no surgeon in the world who doesn't perform minimal access surgery. Even the neurosurgeon, if they have to take a pituitary tumor out, they go through the nose, they break the sella tertia, and they do subsphenoidal minimal access pituitary adenectomy. ENT surgeon, they do FES, that is called functional endoscopic sinus surgery. The neck surgeon, they do the thyroidectomy by minimal access. VATS, video assisted thoracic surgery. The breast, the axilla, the joints, almost every specialization, minimal access surgery is now important. No surgeon can claim himself as a surgeon if he doesn't perform minimal access surgery. It is now mandatory and everyone has to perform it. Without performing minimal access surgery, it is not possible. It doesn't matter that what is your specialization. But most frequently perform minimal access surgeries are only few. All over world, maximum number of the minimal access surgery performed by general surgeon is cholecystectomy. Approximately 40,000 cholecystectomy is performed every day. Second most frequently performed minimal access surgery by general surgeon is appendectomy. Approximately 15,000 appendectomy is performed every day. However, it is old data. Now recent data has increased this number. If you see, third most frequently is hernia, fourth most frequently is fundoplication, and the fifth most frequently is bariatric surgery. These are the most frequently performed minimal access surgery by general surgeon. Coming to the gynecologist, most frequently performed minimal access surgery by gynecologist is diagnostic laparoscopy. Every day 120,000 diagnostic laparoscopy is performed all over world, and maximum number of the diagnostic laparoscopy is performed by gynecologists for the infertility cases. After that, it is also performed by general surgeons for the abdominal trauma. Urologists are performing for the intra-abdominal testes. Then the different type of other specialization like the this oncosurgeons, they are performing to find out the different type of lymph node biopsy and diagnostic. But most frequently it is performed by the gynecologist. Second, the most frequently performed gynae procedure all over world is tubal and ovarian surgery. Approximately 35,000 tubal and ovarian surgeries performed every day. Third, most frequently performed minimal access surgery by the gynecologist is hysterectomy. Fourth most frequently is myomectomy, and fifth most frequently performed minimal access surgery by gynecologist is all type of pelvic organ prolapse, like if it is hysterocele, cystocele, rectocele, all type of prolapse. This is the fifth most frequently they do. Diagnostic laparoscopy is also called electronic eye inside the abdomen, and it was first time performed by Kaling in 1901. This is the original photograph of the Kaling. You can see he is using a torch here and using the naked eye to see inside his dog. Someone has bitten his dog and there was hemoperitoneum inside the dog, and he has done the first diagnostic laparoscopy in the world. The first diagnostic laparoscopy on human was performed by Jacobesque. That was in 1910 on a patient who was suffering from tubercular ascites, and Jacobesque was a Swedish internist who has performed the first diagnostic laparoscopy. Now coming to the cholecystectomy, the first laparoscopic cholecystectomy was performed by Eric Muhe in 1985. However, if you will buy the Indian or the European book, then Eric Muhe was the first. But if you will buy American book, then American give the credit of performing the first cholecystectomy to Moret. Moret has performed, who was first. In Europe and America, 97% of the cholecystectomy nowadays performed by laparoscopy. So, this is the most frequently performed minimal access surgery by general surgeon. Second most frequently is appendectomy, and all over world, all the authors are agree that for female of childbearing age group, laparoscopic appendectomy is gold standard. Do you know why? Because 40% of the time, diagnosis of acute appendicitis in female is wrong. Clinically, we are wrongly diagnosing, because there are many pathology in female pelvis which will give you similar sign symptom as acute appendicitis, like endometriosis, salpingitis, ovarian torsion, simple pelvic inflammatory disease that also can give you sign and symptom of acute appendicitis. So, that is why every author is clear about that a female of childbearing age group, laparoscopy should be considered a better option, because you have an added advantage of improved diagnosis. and you can see that if there is no appendicitis and there is some other pathology, then innocent appendix can be prevented to remove. Almost all the tubal surgery also, sterilization, ectopics, cyst and recanalization is also performed by laparoscopy. Like here you can see in this video that this patient has unruptured ectopic pregnancy, and this instrument which is used here is called tritome. It has three functions. It can inject vasopressin also, it can cut it by the monopolar also, and it has a suction to hold the trophoblast, and you can abort it also. So, these type of instruments are very useful for the unruptured ectopic pregnancy, and not only for this, even for tubal sterilization, tubal recanalization, tubal cyst. For all those tubal diseases, laparoscopy is gold standard. In 1998, first ectopic pregnancy was performed, and now for the advantages that if you will early diagnose, you may not need to do salpingectomy. You can perform the salpingostomy or salpingotomy, and tubal function can be restored, and we can see the trophoblast is out. Then coming to the myomectomy. Uterine fibroid is one of the most common benign gynecological condition worldwide and affecting 70 to 80% of the women at the age of 50. Harry Reich has performed in 1990 the first myomectomy, and today myomectomy, even for the deep intramural myoma and even for submucous myoma, which is more than 4 centimeter, myomectomy is the option, which is the method of choice. But you should have a good suturing and knotting skill. During this course, we will learn all type of knotting and suturing, and at the end of the course, you will be expert in most of the knotting and suturing, which is required in myomectomy. And myomectomy is one of the most frequently performed minimal access surgery. Now coming to pediatric surgery. Albert Einstein has told that there are no great discoveries or advances as long as we have the unhappy children in the world. And almost all the pediatric procedure today, laparoscopy is the method of choice. Only thing what you should must keep in mind, that access should be very careful. You have to use uncuffed endotracheal tube, otherwise there will be vocal cord paralysis. So, this is an uncuffed endotracheal tube. After that, another important thing, that we have to do continuous gastric aspiration, so that acid content should not get aspirated in the trachea of the small kid, it means infant. And rate of flow of the CO2 is very important. In the pediatric patient, rate of flow of CO2 is 0.1 liter per minute per year of the age. So, if the child is 1 year old, then 100 ml per minute, 2 year old 200 ml per minute, and after 10 years it should be same like adult, that is 1 liter per minute. So, pediatric patients are now almost every pediatric surgery of abdomen and thorax, laparoscopy is preferred. Like this is a case of ambiguous genitalia. This child looked like a male child, but actually she is female. So, once the diagnostic laparoscopy was performed, then inside uterus was found, inside ovary was found. If you want to put a needle inside, percutaneously you can drop the needle and then you can perform. You can see that after fixing the tube and ovary, you can see now she is looking like a female child. So, ambiguous genitalia laparoscopy gold standard. Even for Hirschsprung disease, in this there is a distal aganglionic segment. For those patients also, in pediatric patient, there is no ganglion in the distal colon, and those patients just by 3-port you can do the mobilization of the colon much better, because seeing the mesocolic area and seeing the paracolic gutter and mobilizing the colon is always better by laparoscopy compared to open. And after that you can do pull through resection and anastomosis. You can see here, this is just after 1 hour of the laparoscopy, and this is 1 month after laparoscopy. So, these procedure in the pediatric patients are method of choice. Another pediatric surgery which is very popular is esophageal atresia. In this we can see, this is the upper esophagus, this is the lower esophagus, and there is no esophagus in between. So, those patient, if you want to do open surgery, you have to feed the patient by nutrition, parenteral nutrition for 6 weeks, so that baby weight should grow, and then you have to do hemithoracotomy. But by laparoscopy, that is by thoracoscopy, even 1 week old infant you can do by video assisted thoracic surgery, that is called VATS. And you can see here that surgery was performed, and after 2 days baby is in the lap of the mother. So, these pediatric surgeries are very popular. Thoracoscopy can be performed even for resection of the tumor and nodules. You do not need to do the rib resection, and you do not need to cut the sternum. We can see this patient has the lung tumor, and you can go by the intercostal space by endo-GI linear stapler, and then you can fire the stapler, and these nodules of the lung can be resected out. And you do not need to cut the sternum, you do not need to fracture the rib, and it can be taken out. So, these procedures are very rewarding, and that comes in the name of thoracoscopy. After that, nephrectomy for urologist. This is now today donor nephrectomy is also gold standard, because you have a larger pedicle compared to open surgery, less interleukin and C reactive protein will be secreted. So, immunosuppression is also required less, and those are very good, and nowadays almost all the donor nephrectomy all over world is performed by minimal access surgery, and that is slowly becoming the gold standard. Axilloscopy for breast augmentation surgery, thyroid surgery, and even for axillary lymph node resection, minimal access surgery is gold standard. In the old time, it was done by submammary or axillary incision, but now just by giving 3 small port, you can enter into axilla, you can do the lymphadenectomy, you can do nipple sparing lumpectomy, and you can also do the breast augmentation. You can see this breast was augmented, and 10 years later also nobody can say that it is a augmented breast. So, these all procedures can be performed by axilloscopy, and that is one of the branch of minimal access surgery which is very popular. After that, you have the even thyroidectomy also can be performed by axilla. How to do? Just you will give one incision over the anterior axillary line, one subacromion and one areolar, subareolar. And then even in the young female where you do not want any scar over the neck, you can enter and you can do the axilloscopy, and through the axilla you can enter into the neck. You can spare, you can separate the platysma from the sternocleidomastoid, and very easily you can see inferior thyroid vein, and once you will enter there, even the recurrent laryngeal nerve also is very enlarged and magnified view you can see, and you can do even the thyroidectomy through the axilla. So, there will be no scar on the neck. This is also a very good branch which is emerging. After that, another very important branch is hand assisted laparoscopic surgery, that is called HALS. What happens sometime that you cannot use morcellator always, because sometime at the end of the surgery you have to enlarge the incision to remove the organ. In those situations, you can prefer hand assisted laparoscopic surgery, and this is called omniport. Omniport is very popular. Omni means universal, and it has 2 rings. This is one ring will go inside the abdomen, other ring will be outside the abdomen, and you can pump the air, and after that you can introduce your hand inside. So, it will be very useful, and at the end once you will deflate this omniport, then it will act as a wound protector, and then you can take the organ out. So your telescope is also inside the abdomen, your instruments are also inside the abdomen, and your hand is also inside the abdomen. So that is called hand assisted laparoscopic surgery. That is also very popular branch of minimal access surgery which is emerging. And there are many company, one of the Ethicon is making by the name of lap disc. This is called lap disc. And you can see it has two discs. One disc is inside the abdomen, other disc is outside the abdomen, and you can push your hand inside the abdomen. And after that, you can tight it outer one, and then you can support with the hand the organ you want to perform, and then you can do hand assisted laparoscopic surgery. Your telescope is also inside, your instrument is also inside, and your hand is also inside. And at the end, you can deflate it and it will act as a wound protector and you can take the organ out. After that, you have another branch that is called gasless laparoscopic surgery. In this branch, this is the instrument that is called abdolift. Abdolift can replace the pneumoperitoneum. You don't have to put the gas inside the abdomen. And this abdolift is very popular and you can do gasless laparoscopic surgery. So it will lift the abdomen and you don't need CO2. It is very important and especially in high risk pneumoperitoneum patient, it has an added advantage that it will not press the vena cava, it will not press the diaphragm, and it can give you working space so that you can move your instrument, you can move your telescope and you can do gasless laparoscopic surgery. Another important branch is mini and micro laparoscopic surgery. If your instrument is 3 mm, then it will called as a mini laparoscopic surgery. And if your instrument is 1.5 mm, then it is called micro laparoscopic surgery. This is also very important and there are many micro and mini instruments are available like micro alligators, mini alligators. These are the striker alligators. These alligators has the advantage that it can directly can be introduced by the percutaneously and then it can decrease your number of the ports and you can do the cholecystectomy, appendectomy, salpingectomy, oophorectomy all by the use of the mini and micro alligators. After that, you can also perform the single incision laparoscopic surgery. Here instead of 4 incision, just a single incision will be given and in this single incision Sills port you can put another 3 port and there is no need of the multiple port and in the one port 3 port enters and that is called single incision. The size of the incision will be 20 mm and it will be in the umbilicus. So that umbilicus has a great capacity of hiding the scar. So once you will perform the surgery and then you will remove the Sills port, hardly any scar will be visible and it is very adaptable and very popular. Nowadays, even the single incision robotic surgery is also getting popular worldwide. After that, you have MALS. MALS means magnetic assisted laparoscopic surgery. And there is one company, Levita. Levita is worldwide popular of making this MALS instrument, in which the tip of the instrument has magnetic device. You can introduce it through the port and then you can catch the gallbladder, appendix, fallopian tube, round ligament, whatever you want, and there is an outer magnet which will attract the inner magnet. And if outer magnet will go lateral, inner traction also will go anterolateral. If outer magnet is medial, inner traction also will be medial. And that way, magnetic assisted laparoscopic surgery can be performed. And at the end, it will take the organ also out and that is very popular. There are many companies which are now making the magnetic devices and magnetic assisted laparoscopic surgery is developing very fast and new magnetic instruments are used. So, what is the purpose? Purpose is that your number of the port will be reduced. You don't need to make the 4 port for cholecystectomy, only with the 3 port you can perform. And if you want to do suppose hysterectomy, then you don't need to have 4 port, maybe by 3 or only by 2 ports you can perform, because it will act as a retractor. One of the port will be acting as a retractor, that is magnetic assisted. After that you can do nodes, that is called natural orifices transluminal endoscopic surgery. In this you don't need to go through the abdominal wall, directly you go through the posterior fornix and you will give a colpotomy incision, and through this node port you have a different instrument which you can introduce. And V nodes now very popular. Not only gynae procedure, even the general surgical procedure like cholecystectomy, appendectomy, all you can do by the posterior fornix. And then this posterior fornix also will act as a tissue retrieval, and you can use this is 15 endoscope through which you can perform. And just like upper lower GI endoscope, it has an angulation wheel, and through which just like upper lower GI endoscope you can perform natural orifices transluminal endoscopic surgery. Present status in the world is that cardiac tumor surgery, cardiac bypass surgery, valve replacement surgery, all you can perform by minimal access surgery. Like in the older time, when suppose you have to do valve replacement, then you have to give incision, but now there is no incision required, just you need intercostal one incision, and through in between the rib you can put a port, and then you can enter inside and you can cut the pericardium. After that you can enter into the heart, you can give the stay suture over the pericardium so that you have a working space, and then you can use the different type of suture. And after that, here is the Dacron valve. If you see very carefully, the valve is introduced. This is the valve here, this is the valve, and after that you can fix it by the extracorporeal square knot, and you can use Clark knot pusher. There are different type of knot pusher. In this course we will learn all type of extracorporeal knot, and we will see that how to use this type of a square knot to fix the valve, and you can fix the valve, and after that you can close the heart. And then heart, right now the patient is on heart lung machine, so you can see heart is not beating because patient is over the heart lung machine. And once the valve is fixed and heart is closed, then again you will start the pumping of the heart. So you don't need any sternotomy and you can perform. So these are the present status in the world where these procedures doesn't need. In that old time you need to cut the sternum, fracture the rib, but now by the minimal access surgery you can do extracorporeal knot and you can suture it very nicely. In laparoscopy there are 2 type of knot which you must learn. One is extracorporeal like Rodder's knot, Melger's knot, Tay-side knot, Western knot, Mishra's knot, and then inside, that is intracorporeal, and both we will learn during the course, and we can see the heart is getting closed. Present status in the world is that you can do Da Vinci robotic surgery. You know there are 51 type of robots nowadays in the market, most popular and increasing day by day, and new robots are coming. Ethicon has also launched just 1 month ago their own robot by Johnson and Johnson. Da Vinci is the most popular, and you can do Da Vinci robotic surgery. So you don't have to touch the patient, remotely you can perform, and that is called Da Vinci or other robots, and those are getting popular worldwide. And these have a 4-arm completely, and you have the HD or 4K vision is also available. First telesurgery in the human was performed in 7th September 2001 from New York to Strasbourg by using the GS robot. In India, we have performed the first telesurgery, and that was by our Made in India.
Thank you so much, Dr. Vishwa. And
Mantra
I'm
robot.
sure everyone sitting here is now excited to know so much more about SSI Mantra 3 and what makes it so superior and technologically so advanced. I would now like to invite the man himself, Dr. Sudhir Srivastava, founder chairman, SS Innovations, a pioneer in robotic cardiac surgery, and who is also recognized as the father of robotic surgery in India. Dr. Srivastava's passion and love for his motherland pulled him back to his roots so that he can contribute in revolutionizing the surgical robotics for India and the world. Dr. Srivastava, may I please request you to address the gathering now?
Good morning, and thank you, Shruti and Vishwa, for your kind introduction of so many people. I want to extend my also personal welcome to you all. There are a lot of very familiar faces, colleagues, friends, and media, many of you I've talked to, and our team and the family from home. So great to have you all here. Where are we heading to future? We've held single arm applications for tele-diagnosis and teletherapy. And I think we are going to achieve that. And final thing would be, of course, telesurgery. And this is how we have performed. We have partnered with Airtel. And the first one that was done at World Laparoscopy Hospital, it was done through RF transmission. And even then, hardly any latency. And this procedure was gallbladder, just over an hour. There were no transmission issues, system issues, no complication, no perceptible latency. And this is a little video of the surgery. And as you can see, the system is at World Laparoscopy Hospital. Dr. Mishra is sitting in our office in Gurgaon, 5 kilometers away. And I must say it was really remarkable because the whole telesurgery concept existed back in the 80s when NASA and Defense Department of United States funded the research to be able to operate in long distance in space or in battlefield. Now, with the technology capabilities as well as available high-speed connectivity, it's all real. And this is really what's going to change as we move forward in bringing the care to people instead of patients having to travel.
So this we have performed the first telesurgery, and we have the robotic training also in our India branch and USA branch. In Dubai branch, we will start robotic surgery soon. And this is very important because you can do globalization of surgery and we can perform. Another very interesting innovation in the minimal accessory, transvaginal robotic surgery. And this is a hominis robot. And by this robot, you don't need to give incision over the abdomen. This robot can enter through the posterior fornix. And after that, it will take complete 180-degree angle. It can go backward direction, and then you can do hysterectomy, myomectomy, ovarian cystectomy by transvaginal robotic surgery. And what the advantage you have, that you are sitting on the console, you don't have to worry about the mirror image, because it will show you back, but it doesn't give you mirror image feeling. And you will see in front just like simple how you are seeing on the monitor. And your movement robot will translate inside the abdomen of the patient. And this is also getting very popular, and this is called transvaginal robotic surgery. Hominis is the company which is making this robot, and many other companies are also coming. And in the future, in the female, with the transvaginal route, you can perform almost all the hysterectomy, myomectomy, ovarian cystectomy, endometriosis, and other surgeries. And even general surgeries also can be performed. Another very important innovation in laparoscopy is virtual reality. That is called virtual AI, artificial intelligence. And right now, when you are performing, you have the problem. What is the problem you have? That you are seeing on the monitor and performing on the patient. But now you will use the glasses, virtual glasses, and then you can perform the procedure in the virtual environment, and you don't have to hold any master controller. With the finger directly, if you will try in this virtual field, if you will try to catch the fallopian tube, your movement of the hand robot will translate inside the abdomen of the patient. On the animal, this type of trial has already started. On the human also, it is going to be started. The virtual reality projection robotic surgery, and that is the real future, where you don't have to look at the screen, you will see the hologram, and with the finger, they are not dancing, they are operating. And once you will operate this way, your movement of the hand, the robot will translate inside, and you will see the augmented reality that will be very enlarged and 3D environment, and that will be the future of the surgery. Important of the animal dissection also is very important. In this course also, we will have the opportunity of the animal dissection. World Laparoscopy Hospital is the only institute, even in India, even in Dubai, and even in our American branch, we have the facility of animal dissection. And here also in the Swan model, you will do the animal dissection during the course. So conclusion is that minimal access surgery is not a luxury. Now it is necessity of the new millennium, and we should not only offer this technology to the people who are rich, we should also offer to the last person of the community. Do you know why? Because maximum advantage of the minimal access surgery is for the people who are poor, because the poor people has a problem that they cannot afford the means long stay in the hospital. They need faster recovery, they need return to their work early, they need minimum hernia, they need minimum infection. So basically, in my opinion, laparoscopy is a surgery for poor, because the poor people, the day they will not work, that day they will not eat, they will be fasting. So they need early return to work, they need the maximum early this recovery. So that's why we should always offer to this surgery even for the last person of the community. So I am stopping here this introductory lecture, and I will be very happy to answer if you have any question. So I can see all of you. So if anyone just sitting there, if you have any question, please ask and I will answer it.